All right. Well, welcome everybody. I think we can get started now that it's 5:02. Good evening and welcome to the Head and Neck Cancer Survivorship webinar series developed by the Head and Neck Cancer Alliance and the American Head and Neck Society. Our session is titled Managing Insomnia in the Head and Neck Cancer Population. I'm Dr. Warren Swegal, a head and neck surgeon in the Division of Otolaryngology, Head and Neck Surgery at Allegheny Health Network in Pittsburgh, Pennsylvania. And I want to thank our presenters this evening, Dr. Marci Lee Nilsen, Dr. Amy Williams, along with Shant'a Miller-White, our Head and Neck Cancer Alliance Ambassador, for presenting on this webinar today. After our presentation, we'll have a question and answer session where our panelists will be able to answer some of the questions you pose live. These can be submitted through either our chat box or the Q&A buttons at the bottom. Or if you'd like, you can raise your hand and we'll try to call on you live throughout the question and answer session. Volunteers will also be trying to answer some of the questions live during the presentation. With that, I'd like to begin with a few brief introductions. We'll start with Dr. Marci Lee Nilsen, who is an assistant professor at the University of Pittsburgh School of Nursing, Department of Acute and Tertiary Care. Dr. Nilsen's program of research focuses on identification and management of symptoms and treatment-related effects in head and neck cancer survivors through the development of interventions targeted to meet the unique needs of this patient population. Next, Dr. Amy Williams is the Director of Research for the Department of Otolaryngology, Head and Neck Surgery at Henry Ford Health System in Detroit. As a core member of the multidisciplinary head and neck cancer team within the Henry Ford Cancer Institute, Dr. Williams works with patients and their families providing psych oncology services across the care and survivorship spectrum. And last, our Cancer Alliance Ambassador, Shant'a Miller-White. She is a mother of twin daughters. She is a CEO and founder of Parents Against Bullying Virginia and resides in Hampton, Virginia. She is a throat cancer survivor. Shant'a now serves as a Head and Neck Cancer Alliance Ambassador. And Shant'a will share her cancer journey and how she slowly learned to manage her insomnia. And with that, I invite her to open things up.
Good afternoon, everyone. Again, my name is Shant'a Miller-White. I was diagnosed with head and neck cancer in May of 2019. Choking was a thing that I did not know at the time was a sign. And during that time, sleeping was very hard for me because of the reasoning behind the choking. I was very afraid to possibly go to sleep and choke to death. But going on during the course of this, I went through my first surgery, which was back in May of 2019. And after that surgery, it was even harder to sleep. One, because of the pain from the incisions and things that they had to do to me. Two, because I was still choking, even though I had the first surgery. Going back for my follow-up, just a few weeks later, was when I was told they found cancer during that first surgery. The choking still continued and the sleepless nights still stayed abreast. One, stressing out because I didn't know what was going on. I didn't know what to expect. The pain was still there and the unknown was in my mind. So sleeping was a very hard thing to do. During my second surgery, of course, after my second surgery, which was 7.5 hours long, I have now an incision from behind my ear to the middle of my throat. And the pain from that, once I was home, trying to recover, the pain was excruciating. They cut a portion of my tongue as well. So I had to deal with that, as well as cutting more area out from around where my tonsil sat from the first surgery. Still, those sleepless nights. I went from sleeping maybe 3 to 4 hours of sleep. I had an amazing team of doctors, but Dr. Karakulan was my oncologist surgeon, and he definitely gave me tools to help me to be able to just relax. He told me to just learn how to suck, swallow, and breathe again to try to slow down that choking during this particular part of this. And he gave me a few things such as some medication to help me to rest, but nothing too strong. But again, it was just learning how to deal with all the things that had went on so fast with this whole journey. After my second surgery, I did not have those sense of taste, sense of smell, and still that pain in my neck. So it still was hard for me to adjust, to get comfortable, to be able to sleep, and still learning how to suck, swallow, and breathe. I tell you, going through this journey has been something else, but I didn't have to go through chemo or radiation, but learning how to do certain things all over again was definitely a challenge, but I made it through. So just know that during this time, you with the help and with the support, you can make it through. So I'm just here to tell you that those sleepless nights now have turned into 8 hours of sleep now, and I'm so glad that I'm able to rest. I do have one or two peeping nights that I can't rest that long, but I tell you, it's good to be able to now sleep for 8 hours a day. Insomnia is something else. But I wanted to let you know that this journey will get better. Thank you so much for tuning in today.
Excellent. Thank you very much, Shant'a, for your presentation and your giving us your experience. You've been through a lot, and we appreciate you sharing. Next, I'd like to turn it over to Dr. Nilsen.
So insomnia is one of the most common sleep disorders that adults experience. And so we're going to talk just generally about insomnia and then kind of how it's different for head and neck cancer survivors. And so insomnia can happen with no underlying medical reason, or it can happen because of a medical condition or a mental illness or disorder that kind of exacerbates or makes difficulty sleeping difficult. So about 30 to 40% of adults do experience insomnia. And actually recently there's been some information or data to show that this has actually been increasing. And that doesn't account what's happened in the last year with COVID, but that insomnia has become more prevalent. And so what is insomnia? So insomnia can manifest in a couple different ways. It can be problems falling asleep. It can be problems staying asleep. It can be waking up too early in the morning. So in general, you're just not getting good quality sleep or getting the recommended kind of 7 to 8 hours of sleep a night. And this can be something that is short-term or long-term, that it happens more than 3 times a week for greater than 3 months. And in the end, insomnia can be experienced differently across people. So one patient may come in and say, you know, I lay in bed and it just takes me 3 to 4 hours to fall asleep. And then once I get to sleep, I'm good through the night. While another person may come in and say, you know, I fall asleep fine. I go to bed at 10, but then I'm up at 11 and 2 and 3 and 4. And so it really can be manifested differently across people. So what are the signs and symptoms? So I've already mentioned some of them: difficulty falling asleep at night, waking up during the night, waking up too early, feeling not well rested in the morning, or having daytime sleepiness or drowsiness. There can be irritability, depression, and anxiety. There can be difficulty paying attention. So this gets to the kind of cognitive effects of not getting enough sleep. So difficulty paying attention, focusing on the task you're supposed to do. So if you're trying to, you know, pay your bills, it's hard to kind of calculate those numbers and put it together. You're having difficulty remembering the tasks you're supposed to do, which comes to increased errors and accidents, and ongoing worries about just about sleeping. So these are just some of the signs and symptoms that people may experience. And so what are the common causes or risk factors? And so these will differ, and we'll talk about how, but in general, in the general public, as you get older, older adults do experience more trouble sleeping. So about 50% of older adults report difficulty sleeping. Sex and gender, so women tend to report more trouble sleeping or trouble with insomnia. So stress, if you have a lot of stressors, if you have work stressors, family stressors, relationship stressors, these can contribute to insomnia. If you're a shift worker or have irregular patterns, so you work nights and you work days and you work nights, this can increase the likelihood of experiencing insomnia. Or maybe you just don't have regular sleep patterns. One day you go to bed at 11, the next day you're in bed at 1. This really can kind of throw off your circadian rhythm. So that means that you're not having those periods of sleeplessness and arousal at the same time. And so it just kind of makes it more difficult for you to fall asleep and stay asleep. Lifestyle or environmental factors, if you're drinking a lot of caffeine, if you're using, smoking, some other like lots of loud noise where you're at, or maybe temperature. These are just some environmental factors that can affect sleeping. And insomnia and depression and anxiety and depression contribute to insomnia, and insomnia can worsen anxiety and depression. So it can kind of go both ways. But again, worrying and stressing does affect your ability to sleep. Underlying health conditions can contribute to an increased risk of insomnia. And as Shant'a mentioned, pain. So any condition that causes pain, arthritis, anything like that can impair your ability to kind of get comfortable or stay asleep at night. If you roll onto an arm that you've injured, you may wake up. And again, it may be have trouble getting back to sleep. And then some medications can have a stimulating effect. So depending on when you take them, it can make it harder to fall asleep. And if you take a medication during the day that makes you drowsy, you may start to sleep during the day and it's harder to fall asleep at night. So those are some of the general causes and contributing factors to insomnia. So what's different about head and neck? What do we know about head and neck? Are patients more and survivors more likely to experience insomnia? It really depends. And so it does vary also. And it varies across your survivorship phase. So survivorship phases are just how we talk about in like before treatment, in treatment, kind of the period right after treatment. And then for people in that permanent phase or people further out from their treatment, we're talking 5 to 6 years. And survivors who are undergoing treatment have the highest rate of insomnia. And so you can think about to some of those causes, like pain can contribute and maybe the reason why. Patients before treatment do have about 30% of them experience insomnia. And so these are pooled numbers. This came from what we call a systematic review, which is a study that looks at all the studies published on a certain topic and kind of gives us an average. So, and it just does vary, but these are in general. And you may say, well, you know, mine was worse before. And again, it's just kind of an average. And then at the end of treatment, about 40%. So we're still on the high end of the general public. So 45% is over the rate. I mean, 40 is right at that high end. So risk factors and causes of insomnia, some are similar to the general public, but some are different. So one example of the risk factors that I've already mentioned are pain. So things that you may experience during or after treatment, or even before, could be pain related to the cancer, pain related to the treatment, things like mucositis, neck pain, so neck pain related to surgery, or neck pain related to radiation, depression and anxiety. Again, I mentioned, so depression and anxiety can kind of precede insomnia, but also if you have insomnia, these could exacerbate anxiety and depression. So worrying. Dry mouth. So dry mouth, one, it's uncomfortable. It may cause you to have more mucus at night, which then you wakes up because it bothers you. It makes it harder to breathe. But also dry mouth, you probably are drinking a lot of water in the day. You know, most of my patients come in with water bottles, and then what happens is they're up a lot at night and maybe they have trouble falling back to sleep. Presence of a trach tube. So this could get to some underlying conditions. Patients may be really sick. They may have some difficulty with their airway. It also may be uncomfortable, which contributes to difficulty sleeping. Patients who have a lot of things going on, so comorbidities, people who have higher rates of these also have trouble. And in contrast to the general public, people of a younger age seem to report more insomnia. And this may be because they're used to sleeping really, you know, at a regular rate, and now they're more disrupted than they have ever been before. As somebody who is older may already have trouble sleeping. And so this is only a small exacerbation of what they're experiencing. And so that's some of the postulation of what may be different between the general public and younger head and neck cancer patients. And so how are you diagnosed? So if you are experiencing insomnia, even if you kind of have an idea of why you're experiencing insomnia, you should really talk to your healthcare provider. And they're going to help you with a diagnosis related to your symptoms. So the diagnosis process may be or should be a really thorough medical history and physical examination, trying to see if there are underlying causes, if this is new, if it's been persisting for a long period. And Dr. Williams will talk about sleep diaries. So I won't touch on that, but also blood tests, again, because of these underlying medical conditions. If there's something that we can treat, then this may help deal with the insomnia or come up with strategies for the insomnia. And then sleep studies. So a sleep study may be a good idea because sometimes insomnia does also happen with other conditions such as sleep apnea. And the reason insomnia is important to diagnose and really try to manage is because we do know that it exacerbates certain mental health conditions like anxiety, depression. It can also contribute to other health conditions or deteriorate or make your health more not as optimal as you would like. And also it can affect patients' quality of life. So it's really important to bring it up and address it with your medical team.
All right, so I am going to talk about the interventions for insomnia. Now that we know that it happens, what the heck can we do about it? And I often refer to insomnia as kind of a dog chasing its tail. There are a bunch of things that contribute to it, some of which we have control over, some of which we don't, those predisposing and precipitating factors. But what optimally happens is that you sleep badly at night, and because you slept poorly, you're tired throughout the day, you're stressed throughout the day, your fuse is shorter, and then you compensate with unhealthy habits. You know, you drink more caffeine, you eat more chocolate, you eat more carbs, you skip your workout because you're tired, you take a nap. And then these habits then affect your ability to fall asleep or to stay asleep that night. And then you're around and around you go because you sleep badly at night, you feel stressed the next day, you take a nap, it causes you to sleep poorly the next day. So I'm going to be talking about the different interventions for insomnia. And they kind of fall into three buckets. There's behavioral interventions, pharmacological interventions, and non-pharmacological interventions. So the behavioral interventions, there's actually a lot of evidence for these, and these are the recommended first line of treatment for any type of insomnia. The easiest one is what we call sleep hygiene education. And I'm going to go into a little bit more about what that means, but really it's education on sleep promoting behaviors, things to avoid doing, and how to create a sleep conducive environment. The other one that is a little more in depth is cognitive behavioral therapy for insomnia. And it is really the recommended first line treatment for insomnia before medications, before anything else. CBTI is where you should be going. So what the heck is sleep hygiene? So sleep hygiene is a bunch of tips and tricks that for those who sleep well, typically, they don't even think about. This is something that they do automatically. And for those who are sleeping well, you don't need to change anything in your sleep or in your day-to-day pattern. But for those of us who struggle with sleep, these sleep hygiene tips are really important to start implementing. And unfortunately, it's not a one-size-fits-all. These are tools in your toolbox to put in and use regularly, and you have to be consistent. Any type of sleep hygiene intervention, you're going to want to do it consistently every single day and night for at least 2 to 3 weeks before you're going to see results. So first and foremost, get regular. Same bedtime, same wake up time, regardless of the day. If it's the weekend, you don't sleep in and you still go to bed at 10 o'clock at night and get up at 6 a.m. Create rituals. Do things like brush your teeth, read, do some calming breathing, get into bed. Sometimes having a bath about 1 to 2 hours before bedtime can help. And you want it that far ahead of bedtime because what happens when we start to prepare for sleep is that our body temperature naturally falls. So if you have a bath and then you immediately go to bed, your body temperature is actually higher than it should be in order to go to sleep. So we trick our body into having that temperature fall by having a bath about an hour or two beforehand. Eat a healthy diet. So timing of your meals and snacks, making sure that you're not eating large meals within a couple hours of bedtime, but also making sure that you're not going to bed hungry. Avoiding caffeine and nicotine for 4 to 6 hours before bedtime. So both of these are central nervous system stimulants and are going to keep you up or make sure that you're not getting into a good restful sleep. Avoiding alcohol about 4 to 6 hours before bed. And oftentimes people will say, yeah, but a drink helps me fall asleep. And it may help you get to sleep, but it's going to prevent you getting into a good restful sleep. And it's going to pretty much guarantee you waking up in about 2 to 3 hours and not being able to get back to sleep. Go to sleep when sleepy. So if you aren't asleep after about 20 minutes to a half hour, don't stay in bed watching the clock. Don't stay in bed counting sheep. Get up, go to a different room, do something quiet. No screens, no TV, no tablet, no computer, no iPhone. All of those emit a wavelength of light that's going to wake your brain up and it's going to be counterproductive. I often tell folks, take up crocheting, read a book you've already read, flip through a magazine, fold clothes, those sort of things. Do things that you can leave as soon as you feel tired. And when you feel tired, go back to bed. If you aren't asleep after 30 minutes, get out of bed, rinse and repeat. No clock watching. That counting down the hours until you have to get up and calculating how little sleep you have left is actually going to increase the anxiety and make it harder to get to sleep. Save the bed for sleeping. It means no reading in bed, no watching TV in bed, no arguing in bed, no just hanging out in bed and resting your eyes. If you're not sleeping, get out of bed. Make sure your room is the right space for sleeping. Our body likes cool temperatures, oftentimes in the 65-degree range, with warm blankets to keep us warm. That it's dark, and if your room isn't naturally dark, things like eye masks, blackout shades can be helpful. That it's quiet. So we don't want the TV on in the room, because what happens is, and you've probably noticed this, is that late at night, as the TV show is on, it's nice and quiet, but then the volume goes up when it comes time for the commercials. That can wake you up even if you aren't actually aware of it, and that gets you out of that good restful sleep. Oftentimes things like a fan or an air conditioner or a white noise machine is better to kind of block out the noise around you. Keep a sleep diary. How do you sleep? What gets in the way of that? And we're going to show you that in a second. Pets and partners. This is a tough one. So oftentimes we love our pets and we want them to share the bed with us. However, they are oftentimes fairly nocturnal and will be waking us up regularly. And while you may not wake up fully, it's pulling you out of that good restful sleep and making it more likely when you get to that less restful sleep that you wake up because they're moving around. And also making sure that you're getting regular exercise, but that you don't exercise within 4 hours of your bedtime. Has to do with that increased body temperature piece. So cognitive behavioral therapy for insomnia is kind of that one step further. We're going to do all of those sleep hygiene pieces. We're also going to talk about stimulus control. So changing the associations in the bedroom, limiting what is done in the bed and what is done in the bedroom. Again, using that if you're not asleep after 30 minutes, get out of bed, go to a different room, and consistent bed and wake up time. And that helps reprogram your brain. I often tell patients when I'm working with them, I'm like, your brain's a jerk and it's going to learn that it can do lots of fun things in bed if you're not sleeping. And it's always going to choose those fun things over the boring sleep. So making sure that what you're doing in bed is sleeping and helping your brain make those associations. Sleep restriction therapy, which is limiting the amount of time in bed that you're not sleeping, which means that if you're not asleep after 30 minutes, you're getting out of bed, you're going to a different room, you're doing something quiet, you're maintaining that early wake up time, that normal nighttime bedtime, and you're going to avoid napping during the day because this is going to increase your drive for sleep. using a sleep diary, shifting your sleep a bit to compress sleep. And this is important to work with a psychologist or a therapist on, because there's calculations involved on how to best compress your sleep. And then adding additional components, things like relaxation training, cognitive restructuring, or thinking about those worries differently. A lot of education about how sleep works, and that we have 90-minute sleep cycles and they kind of go like a wave, and why it is we oftentimes wake up at about 2 or 3 in the morning, and kind of talking about that so that we restructure how you're thinking about it, and then using those sleep hygiene strategies. This is an example of a sleep diary, and there are lots of really good ones online. You might want to look up some if you're having difficulty sleeping, but it looks at how you feel in the morning, how you slept, and then the things that you do during the day: caffeine, nicotine, alcohol, medications, exercise, meals, those sort of things that might be contributing to that poor sleep at night. Some non-pharmacological interventions, so exercise, getting at least 30 minutes of exercise a day, so walking, biking, you don't have to run a marathon, and not exercising within 4 hours of bedtime. Particularly for those of us who are wired a little more anxious, exercise is really like a release valve on a radiator. That exercise lets out that anxious energy and makes it easier for you to sleep at night because you're not as tense and wound up. Tai Chi or yoga can be helpful. Acupressure or acupuncture, particularly auricular therapy, so around the ear, can be beneficial in sleep quality. Bright light therapy is one where you're exposed to a bright light that's positioned about 16 to 24 inches from your face for about 20 to 40 minutes. And usually this is best done right as you first wake up to help kickstart that the hormone that then drives your sleep drive at night. Some of the pharmacological interventions, I'm sure those of you who have sleep issues have probably heard some of these. So the sedative hypnotics, which have moderate evidence, kind of the use of a big hammer to get you to sleep. And we want to make sure that we're avoiding or limiting the length of use of these medications like Lunesta and Ambien, or the benzodiazepines like Xanax or Ativan, particularly in adult and older adult populations, because of the effects on your cognition or the way that your brain's working, and also the fall risk that can go in with these medications. With these medications, there's also issues with dependence or needing a higher dose in order to get the same effect. And then rebound insomnia. Once you stop the medication, the effects of the medication are no longer there and you go back to having insomnia. And you don't tend to see that when you're using things like sleep hygiene and cognitive behavioral therapy, because those are permanently altering your behaviors, whereas the medication only works that night. So that I talked about the risks of falling, worsening cognition, and delirium or confusion with those. Sometimes we'll use things like older antidepressants like mirtazapine or Remeron, which can be helpful with comorbid depression and in cancer, particularly the mirtazapine, because it can stimulate the appetite as well. Trazodone or Deseril is another one that's used, and it's helpful for sleep onset at times, and it doesn't have those physical dependence concerns. Herbal supplements, you've probably heard a lot about melatonin. There's a lack of good research. Most of the research that's out there that supports melatonin is in the case of jet lag, which if you're having insomnia, it's oftentimes not due to jet lag. And with melatonin, higher dose is not better. I think the studies that I've read top out at about 5 milligrams as the most effective dose. But it can help intermittently with sleep onset, and it's good in the setting of folks who have had issues with alcohol in the past or drugs in the past, because there isn't the risk of dependence. And then valerian is a difficult one to use because it's very difficult to get consistent formulation. So you're never quite sure how much you're actually getting of the actual drug in the tablet. And as with any pharmacological intervention, making sure that you're talking to your docs about this, because there is a lot of other considerations that need to go into this in addition to your sleep issues. And some of the resources that I would recommend: the Sleep Foundation has some really good information about insomnia, as well as some good sleep diaries. And then the CBTI app there is offered through the VA, and it is a mobile app on your phone. It's free because it was developed through the VA, and it's meant to be used. It works best when used with a therapist where you're actually doing CBTI, but the sleep pieces of it can be very beneficial even if you don't have a therapist that you're working with.
All right. Well, thank you to our panelists for those wonderful presentations. I think we'd like to move to the question and answer session. Don't forget that you can submit questions through the chat function as well as the Q&A buttons. And if you'd like, you can try to raise your hand and we'll try to answer some of those questions live. So I recorded a couple down here, if we can get to some of those. A lot of the chat box was centered around dry mouth and insomnia. I was wondering if the panelists could provide some perspective on how to treat dry mouth, how that can affect sleep. Maybe if Shant'a, if you have a specific experience you'd like to share to start.
Yes, dry mouth is something that I do deal with a lot. And I know that it's days where I have too much saliva, and then there's days where it's very dry. It just depends. I don't know why it is, and I can't like pinpoint when it occurs. But during my sleep, I have not been able to sleep because of either the dry mouth or too much saliva in my mouth. So that is something that is it's irritating, and I know that it is because I do suffer with it. But all that I do is I'll get up and I'll get water or what have you.
Thank you. Dr. Nielsen or Dr. Williams?
So I think dry mouth is something that is very difficult because I can tell you what one patient will say, and then the next patient will say, well, I tried that and it did not work. So the big things that people do use are things like biotin. Sometimes patients can put, if like the sensation is your tongue's dry or your gums are dry, using something a little bit more viscous. So even a little bit of olive oil on your gums can help with that sensation of dryness. And keeping a water bottle next to your bed, as long as you obviously can drink safely. Some people do think that a little bit lukewarm water, especially if your dry mouth causes you to have thicker secretions, that can help break up some of the secretions. And so sometimes people keep a thermos. And so then if they wake up at 1 or 2, they can kind of take a drink and help clear their mouth. So there are other products out there that people use. There's a product called Refresh, which is like biotin, but those kind of replacements are what people use. Obviously, the more viscous it is, the longer it sticks around, as opposed to something that's really a thin consistency. But it is something that you kind of have to trial and error.
I will also say we often talk to folks, particularly in our Michigan winters when things get nice and cold and the inside of the house gets real dry. We talk about a good bedside humidifier and making sure that that thing is running on you all night long to prevent that whole tongue stuck to the roof of the mouth piece. I also talk to folks about having the baking soda salt rinse either at bedside or at bathroom cabinet ready to go, and using that to kind of break down some of that excess mucus.
Excellent. Thank you. One other issue that was brought up by one of the participants or one of the attendees was questions from family members regarding the insomnia. Obviously, the insomnia just doesn't affect just the patient, but it also affects the people around them. How do we have that discussion with our family members and kind of start that discussion?
It's a tough one because it's hard to explain insomnia to somebody who sleeps well and they just don't understand. They're just like, just go to sleep, right? Just put the book down, just put the phone down. And then they get frustrated when you're more irritable the next day, or you can't focus the next day, or you're needing to take a nap the next day. It really needs to be an open conversation with family members. You know, there are things that oftentimes I'll work with partners where sleeping in the same bed doesn't work, and having the conversation about how sleeping in different bedrooms might be the best for both people for insomnia, or getting the pets out of the room, or turning the TV off and getting the TV off out of the room, and needing to have these open conversations in service of good sleep, which then is in service of a better relationship because there's less irritability and anxiety associated with it.
I also, you know, when we talk to our patients, a lot of times I mentioned that this is not just something that the patient goes through. So cancer treatment, they're obviously experiencing the changes, but the anxiety and the worry can also be something that caregivers experience. And so, you know, while we're set up in the clinics to really deal with patients, that doesn't necessarily mean that we can't help provide loved ones with resources. We do have, like, a lot of centers have places that not just patients can go, but caregivers can go also. So these are resources that not only a patient, but also their loved one can use to try to, you know, work on their sleep hygiene and work how they're sleeping. And if it's something related to the anxiety going along with your loved one being through treatment, you know, there are things that there are organizations and services usually within most hospitals that can actually target caregivers also.
If I could just say that one of the things that did help with me and my family, and I wear a mask that says I'm a survivor, and my family had it as well, because you do need to have support. I will say that the social worker that I had once I was released from the hospital from my second surgery gave a lot of information about support groups for, you know, head and neck cancer, which was, you know, what I fell under the umbrella of. And it had so many different topics on what they had support for. And insomnia was one of them. And there's so many other things so that your family can understand, because sometimes it is harder for the patient to try to explain it to the others when they've been around them for so long, or what have you, or seeing a big difference in them. So if you can get connected to any support groups, and you can find out that information from maybe the doctor that you attend or the hospital that you go to, is very, very helpful. I know that it helped me and my family.
Yeah, and support groups can be for both the patient and the caregiver together. They can be for patients, or they can be for caregivers alone. So there's a lot of different ways, depending on what everyone's comfortable with, getting support that's needed.
Agreed.
We talked about how issues like anxiety and depression can lead to insomnia. Some of the attendees had questioned, how does insomnia exacerbate some of those issues, and could it potentially lead to other more serious mental health issues?
Absolutely, yes. So one of the key symptoms when we're looking at symptoms of depression and anxiety is disrupted sleep. So either you're sleeping too much or you're sleeping too little. And that then, when I talk to folks about sleep, when we are not sleeping well, when we are not feeling physically well, it is very difficult for us to manage emotions. I often talk about, normally our levels up here, and, you know, we kind of bounce around down here, and this is our ceiling. When we don't sleep, we're more here, and we have a much shorter fuse because of that. And then that leads to conflict, and then it leads to avoiding one another, which then leads to that social withdrawal. And if you socially withdraw, you end up in a cycle where you're not doing enjoyable things. When you do see other people, it's conflictual. And then why would you go back into that? And that can deepen the depression and the anxiety to the point where you are on your own. And sometimes that can get to a really dark place. Also, we know that our brain needs to sleep. It needs to sleep to process thoughts. It needs to sleep to process emotions. It needs to sleep to repair itself. And there's actually a fair number of studies that show we can't go very long without good sleep, without having physical issues, without having psychiatric issues, seeing things, hearing things, or without suicidal thoughts. So we really want to make sure that we're getting good sleep. And sometimes to get that good sleep, we have to treat the depression or the anxiety along with the sleep hygiene and the cognitive behavioral therapy that addresses both pieces.
And we do know that insomnia is linked to other medical conditions like high blood pressure or diabetes and obesity. And so that's why, you know, these are important reasons why you need to bring it up. If your providers haven't asked, why you should bring it up to your provider.
Excellent. I have another question here from an anonymous attendee asking about lymphedema and neck swelling and how it can relate to problems sleeping and potentially treatment for lymphedema with regard to sleep. Let me ask Shant'a first. Did you have any issues with lymphedema or swelling after surgery and radiation?
I didn't have to have radiation, but after my surgery, I did have swelling in my neck because they did remove my lymph nodes. And in that area, and it's still a little swollen now, even after, I think I'm going into 18 months now, but it's still a little swollen on the area, which I'm sure no one could probably see it. But yes, I did suffer with swelling, and it's still very sensitive because it's like, I don't have feelings. So it's like if something brushes against it or my clothes is too close or the pillow sits on it, I have to have it just right, because there's still a lot of sensitivity to my neck on the left side where I had the surgery done.
So lymphedema and neck pain are something that we do deal with regularly, even if it's not a lot of lymphedema, but as Shant'a mentioned, it can happen after surgery and it can happen, you know, after radiation and for people who never had surgery. So typically people who are going to help you with lymphedema, because if you have swelling on the outside, you can also have swelling kind of on the inside, depending on how bad your lymphedema is. So it's really important to address it. And physical therapists are some of the best trained individuals to talk to, and you can look for a lymphedema certified physical therapist. And so they can help you work on kind of manual techniques. And if your lymphedema is really kind of not progressing with that, there are compression devices that you can wear. And there are also more kind of pneumatic devices that you can wear twice a day to help combat that lymphedema. With some of the more fancy technology, it's not always covered by insurance, so it is something to discuss with your providers. So you're not surprised if you get a couple dollar bills for these devices. So it is something and a lot of lymphedema certified therapists are really familiar with cancer because they do deal with other cancers like breast cancer and head and neck cancer. So they do understand the discomfort that can come into play with lymphedema and how to really address it and how to help you address it at home, because you know, you may see a nice progression when you're at physical therapy and then you go home and you're like, wait a minute, it's all back. So they have to really teach you to help manage it and kind of give you some of these other strategies.
Great. Another question about other providers who may be able to help when it comes to looking for providers with regard to helping with sleep issues or pain. Obviously, you know, we go to our head and neck cancer team, but other people who may be able to help, say, you know, a therapist or someone in sleep medicine.
Mm-hmm.
So I will say folks in sleep medicine. So if you're getting treatment or you live near an academic medical center, there are oftentimes within sleep medicine, they have a psychologist who's employed that does the CBTI piece, does some sleep hygiene, and really just helps look at the bigger picture as it comes to your sleep. Because while these medical pieces will pull your sleep out of normal, once you're there, you start developing those bad habits, those precipitating factors that are going to then continue that kind of cycle. And you need to start changing up those habits in addition to managing the pain, in addition to having better management of the lymphedema, the dry mouth, those sort of things. There are those habits that are going to still be there that are a result of the medical piece of it. And so they can help identify those for you.
And sleep medicine can also help you kind of identify if there are other things. And sometimes insomnia happens with other sleep disorders like sleep apnea. We do know that patients who've had radiation can experience it.
Mhm.
And so they may do like a sleep study and kind of rule out some other things that they could be addressed along the way. And depending on what other pain you're having, you know, that can depend on where you want to go. It could be physical therapy, it can kind of be pain management, palliative care, and supportive care. So there's it just kind of really is dependent. So that's why it's good to pinpoint, you know, what exactly is contributing, because then there'll be ways to help direct you to what providers can really help you. It may be one, it may be two. So you may
Sometimes
need,
it takes a village.
yes, it's a team-based approach.
I have a question here from a laryngectomy patient. So, you know, a kind of a smaller subset of patients with head and neck cancer undergo procedures where the airway is significantly altered. And they can have some unique sleeping problems. Do you have any suggestions for laryngectomy patients?
It's a tough one because if you, before the laryngectomy, were a stomach sleeper, after the laryngectomy or after a tracheostomy, sleeping on your stomach is no longer an option. Sometimes sleeping on your side is even very difficult. So it's that positioning piece again. Being consistent, all of those sleep hygiene things can work in your favor, as well as talking to your docs if there's, you know, lingering pain, discomfort. Sometimes raising the head of the bed or sleeping on a wedge can be helpful.
Yeah, you know, we have sometimes people say they sleep in a recliner. So if we could get you more towards like a bed, maybe figure out a way to elevate you if that's the problem. You know, people can get creative, but if you're sitting in your recliner by your TV, you're probably exacerbating some of those other habits that are not optimal to sleeping. So if we could get you to a bed and figure out how to get you comfortable there. So it's really kind of tailoring to what exactly is giving, you know, a laryngectomy patient, laryngectomy survivor, some trouble.
Excellent. I have another one or two questions here regarding the supportive services such as PT, lymphedema therapy. What do you do if you can't afford them? Are there options for funding or support that we know?
So oftentimes most cancer centers have patient funds, or, you know, I know for us, we have like a Game on Cancer where money is donated and that can be used for different things for patients. And there are some regulations around medical costs that can be used for. But I know that our acupuncture, acupressure, physical therapy, massage therapy also work on donating time. Some of the local cancer centers also contract with massage therapists or PT groups that will do like group PT or group massage, or they're donating their time for those services as part of the cancer center. That's usually where I refer folks to.
Yeah, so we have a lot of the similar things here. So we have, you know, some of these more complementary therapies, and depending on how much the system gets, there are a lot of opportunities for patients to try a couple things to see if it works. And then if they feel like it does help, they can do it for a reduced rate. So check into a lot of groups do a lot of philanthropy work. Like here, we like to run marathons. I don't know if we like to run them, but we run them. And then we use the funds to help support patient care. So it's really talking to your team. And, you know, I know that going to your team and saying, I can't pay for this, but I know I need it, is probably not an easy conversation. And sometimes it's hard for providers because we do feel stuck. But I think to be open and honest, then that helps us try to figure out how to help you.
Excellent. So Dr. Williams, you had mentioned trying to avoid exercise before bed. Is there any situation or potentially light exercise or stretching that could be beneficial? I have a question here from Rhonda, who was asking about patients who may already have a lower body temperature and finds that light exercise tends to help.
Yeah, so there's a lot of things that kind of light exercise, yoga, Tai Chi can get you. So you don't want to do the heavy stuff. There's no, you know, getting your heart rate up and going, but things like Tai Chi and yoga can actually not just stretch your body and make things more comfortable, but there's also a relaxation component to it. There is a being in the moment when you're doing those exercises that will calm your mind, calm your body, and put you kind of cognitively in a better spot for sleep. So the exercise you should be avoiding is the, treadmill, exercise bike, going for a 3-mile run.
Before you go to
No
bed.
spin class, no, nothing on the Peloton, nothing like that. But that stretching, yoga, Tai Chi, slow movements can definitely help with the relaxation that helps get you better sleep.
Great. And then, Dr. Nielsen, you had commented on comorbid conditions or other conditions such as sleep apnea. What about snoring without sleep apnea? Obviously, it can be disruptive to bed partners. Head and neck cancer patients are more at risk for, or can have snoring associated with it. Any suggestions with snoring alone?
So sometimes it's positional. So it really, you kind of have to try different ways. So if it's positional, like maybe when you roll to your back, you start snoring. So, rolling to your slide, sometimes using a wedge pillow can be enough to kind of help with that. There are other things, you can try. So, but those are usually the more positional things that go along with it, and making sure you don't have sleep apnea is obviously one. You could talk to a sleep medicine person. They probably are slightly better at that. But again, sometimes it's a lot of it's positional. You turn to your side. Again, doing some things that exacerbate snoring, like limiting alcohol and things like that could also be tried.
Yeah, and I would encourage those, if you're experiencing snoring and restless sleep and you have not been tested for sleep apnea, that I would contact your provider or your local sleep medicine team to be tested, as that is a significant risk factor for snore or for sleep apnea. I wanted to ask Shant'a a question in terms of neck pain that you experienced after treatment. Did you ever have pain that woke you up out of sleep? And if so, how did you deal with it? And if not, have you come across that at all?
Absolutely. And one of the things that I also had to go back to my ear, nose, and throat doctor about, because I was having this pain that was shooting from my ear to my neck. And they stated that that's a norm that's due to, the incisions or what have you. Could have been a nerve or what have you that was close to where the area was. So that pain is something that I just have to kind of deal with. I will kind of try to switch positions, get off my left side and get back, try to, like she said, position myself on my right side and it'll kind of go away. Something like that, that of course they advised me to take maybe some Motrin or Tylenol, but they're saying that this is going to be something that I'm going to continuously feel. It's different types of pains in my neck and from my ear to my neck, that whole little left side, and it's all about the healing process as well. It might be looking healed on the outside, but it's still some time in the inside. So yes, hope I answered that.
Thank you. Thank you.
And I think sleep neck pain is more common than, so it's something that I do a lot with. I'm not a physical therapist, but I work very closely with some great physical therapists. And it is something that patients experience and may not even realize that's related to their treatment. We've had patients that come in and say, I must have like the worst, I've had 10 pillows, 10, and none of them help me get comfortable. And so if you have new onset pain that's different, you should definitely talk to your oncologist, but you can also bring up these things because there are other techniques, massage, PT, if you develop kind of that fibrosis kind of, and I'm sure some of you in the audience feel it, that tightening that goes around your neck can contribute to spasms. So dealing with those things can also be done through your oncology team and through kind of complementary services of massage and physical therapists and other members of the team. And they can give you strategies, especially if it's waking you up.
Great. There was another question here about other potential applications or apps on the phone, such as Headspace or Calm. And if there's any suggestions regarding those or general mindfulness techniques.
Absolutely. So Headspace and Calm are the ones that through the past year have really put themselves out there, and they are good. They are scientifically supported. I recommend them to my patients. There are free and paid versions. Insight Timer is another good one. And again, it has free and paid versions. They're good because they have guided meditations. They have progressive muscle relaxation scripts on there, and you throw in the earbuds and away you go for that relaxation piece and helping you kind of center and be more tolerant of those thoughts, feelings, stuff that comes up that gets in the way of sleep. So those are really three really great ones. Another good one is Stop, Breathe, Think. For those of us who are wired a little more anxious, it's a good one to kind of get at that cognitive restructuring piece.
Excellent. And some of our patients who've undergone chemotherapy have some chemotherapy-related hearing loss, and obviously that can lead to tinnitus or tinnitus. Any suggestions in terms of how to deal with that? Obviously, background noise, having a fan on, a noise machine, or some simple techniques. Does anybody have any other suggestions in terms of more advanced?
Well, so obviously otolaryngologists, there's otologists and audiologists. So audiologists, they do have programs to kind of help you deal with your tinnitus. And so those would be great resources. And most of your head and neck surgeons are probably going to know a couple. So those are great resources to kind of help, because even if you have tinnitus during the day that really bothers you, things like hearing aids, nobody wants hearing aids, I know, but they will help you hear, and they can also help with your tinnitus during the day. So talking to an audiologist or one of the otologists is a great start.
I'll say the audiologists are the ones that I send folks to with tinnitus, and then we kind of trade back and forth on the coping with the tinnitus. So the audiologists have some good kind of hands-on things to do, and then I work more in the background on the restructuring, the cognitions, and the way that it gets in the way of life.
Yes, and to kind of go back to other treatments for insomnia that can be the same as tinnitus, cognitive behavior therapy has been another very kind of hard to start, but if done correctly, a good way to treat tinnitus effectively.
Absolutely, there's a lot of evidence for it.
Excellent. Well, seeing that it's 5:59, Dr. Williams, there's one question about, could you just repeat the sleep app that you had recommended, or maybe put that in the chat so that it's that everybody can see it there.
It's CBTI Coach, and you can get it on the VA website. I will copy and paste that into the chat so that everybody has it.
Excellent. Now that it is 6 o'clock, if there's any other unanswered questions, we'll try to reach out to people directly after the presentation. Otherwise, I'd like to thank all of our presenters again and all of the attendees for your participation. Excellent questions. And thank you very much, and have a good evening.
Thank you.